So this is your shoulder. So shoulder joint is basically a complex joint. So what are the joints there? So basically there are 3 true joint and one is your pseudo joint. So true joints are, one is your, this is your, the biggest joint, this is your glenohumeral joint. Then second joint, true joint, is your acromioclavicular joint. These are the 2 common areas where from the pathologies are there which might be causing different types of pain. And another true joint is here. It is your sternoclavicular joint. So, but there is a pseudo joint as well. So, what is that pseudo joint? So, pseudo joint is your, this is your scapula. This is your scapula, and this is your thoracic cage. So, this forms a pseudo joint, scapulothoracic joint. So, that is also a joint, and all these 4 joints together is your shoulder joint. So first let us see the bony part, and then we'll be looking at the ligamentous part, and then some of the bursae which are common causes of pain, and at the end I'll be showing the different muscles and the tendons, which is very important. So to understand the sonoanatomy, the very, very important part is to understand the anatomy very nicely. So first is glenohumeral joint, because that is the largest amongst all these 4 joints. And here the joint is formed by, one is your this humeral head. So this is the humeral head, and this is your glenoid. So glenoid is a very shallow, and that is the reason why there is a labrum which elevates and gives the shape of a cup. So ball and socket joint. So this is the one joint, and here few things other to remember. That, sorry, let me, okay, so here the head of the humerus, this is again the 2 important areas in the ultrasound. Very frequently we're talking about it. This is your greater tubercle, this is your lesser, greater, and this is your lesser. And there is a groove through which the long head of the biceps goes, and long head of the biceps becomes intracapsular, and there it goes like this and get attached at the superior part of the labrum. So this is your course of the long head of the biceps. We'll be showing that later on. So here the greater and the lesser tubercle. So muscles sort of be getting attached there. We'll be discussing the lesser tubercle gets the attachment of the subscapularis muscles. Subscapularis muscles comes like this and gets attached with the lesser tubercle. And in the greater tubercle, there are 3 facets. So in that 3 facets, so there are 3 important muscles that is getting attached there, and I'm trying to erase the drawings. Then I'll be going to the other part. Okay. So if you're looking for the posteriorly, very important structure is your, this is your spine of the scapula. And this spine of the scapula is converted into the acromion. So this is your acromion process, and this is the spine of the scapula. So the spine of the scapula is, whole of this, if you are looking about this whole of this, the scapula, posterior aspect, the spine of the scapula is dividing it into the supraspinatus fossa, infraspinatus fossa. So the supraspinatus muscle takes origins from here and goes below the acromion and comes here, getting attached to the superior facet. And infraspinatus muscles getting attached from the infraspinatus fossa, they are getting attached to the middle facet. And the terespinal will be getting attached from here and will be getting attached into the inferior fascia. So these are in the greater tubercle, these are the three different muscles which will be getting attached at the different part of the greater tubercle. And if you are looking from the anteriorly, anteriorly, I forgot to mention another very important part. What is that? That is your coracoid process. So if I'm again looking back here, so this was your coracoid process. So this is your coracoid process. So coracoid process is also very important because some of the ligaments like coracoacromial ligament is attached here there. Also coracoacromial ligament will be coming from here. It will be getting attached here. Coracoacromial ligament. Then your coracohumeral ligament. I'm not talking about coracoacromial ligament will be coming here. Coracoacromial ligament also I'll be showing you. Coracoacromial ligament is also very important because that is making the tunnel through which the supraspinatus muscles comes. So coracohumeral ligament. Apart from that, the other ligaments which will be going coracoclavicular ligament. Coracoclavicular ligament will be again having the two part. One is the conoid part, another is trapezoid part. And few muscles are also getting originated. One of them is your short head of the biceps muscles, biceps muscles, and then is your coracobrachialis muscle. They are the two muscles. And from this side and from here, another muscles will be coming in the coracoid. Tip of the coracoid is the pectoralis minor. Let us clear this drawing. So anteriorly, these are the few things. One is your bicipital groove, another is your greater and lesser tubercle, and the coracoid process. Now we'll be looking the shoulder joint from above. So if you are looking shoulder joint from above, so this is your acromioclavicular joint. This is your acromioclavicular joint. I am still looking at the shoulder joint from above. So this was your acromial process. So this is the spine of the scapula which is getting converted. So this is your acromioclavicular joint is also a very important source of the pain. So acromioclavicular joint also we have to understand, we have to look under the ultrasound also to see the pathology and also to see the dynamic scanning to see if there is any subluxation or not. So with this bony anatomy, now let us see some of the connective tissues. Some of the ligament I have already shown you, but let us show some of the connective tissues. First, what came here? Let me magnify a little bit. So what came here was your synovial membrane. So first layer after the bone which is covering is your synovial membrane. So you know that the glenohumeral joint is a synovial joint. And after that, there are three important ligaments. This is your glenohumeral ligament. So this is your superior glenohumeral ligament. This is your middle glenohumeral ligament. And this is your inferior glenohumeral ligament. Inferior glenohumeral ligament, nowadays people are telling that the coracohumeral ligament thickness measurement is not that consistent to identify the frozen shoulder. Rather than more important is you're looking for the inferior glenohumeral ligament thickness. That is going more consistent. But again, ultrasound findings for this is not always supportive, but still that is one of the areas that it can do. So this was your the ligaments. Then basically these three ligaments are the thickened part of the joint capsule. So next is your joint capsule. So this is the joint capsule, and just above that joint capsule, another very important ligament, what I have already shown you, that is your coracohumeral ligament. Coracohumeral ligament is starting from the coracoid and coming here, getting attached. It's basically bifurcates and getting attached both at the greater and the lesser tubercle. And if I am adding other ligaments, I have already shown you this ligament. So this was your acromioclavicular, coracoacromial ligament. Starting from the coracoid, it is going to the acromial process. And two other part of the ligament also I mentioned there, it is coracoclavicular ligament. So this part was your trapezoid part of the coracoacromial ligament, and this part was the conoid part of the acromioclavicular ligament. So there are two parts of this coracoclavicular ligament. So this was coracoclavicular ligament, this and this trapezoid and the conoid, and this was the coracoacromial ligament. All this ligament can be seen very nicely. And one vessels goes, like this. We'll be showing that, like this, one vessel will go. So now let us see the bursae. So there are the different bursas there. So this bursa, again, one of the very common bursa is here, the subdeltoid, subacromial. Sometimes some literature says that the subdeltoid and subacromial bursa is basically the continuous. So this was your subacromial, this was your subdeltoid. So maybe most of the times we call it together, subacromial, subdeltoid bursa. That is one of the very common area of the pain. This is little less common area. This is your coracovacial bursa or subcoracoid bursa. There is another small bursa is there, just below the tendons of the infraspinatus muscle. This one, sorry, not taking color. Okay, so the bursa below the infraspinatus, and another on the top, that is subcutaneous acromial bursa. That is very superficial and sometimes very, just close to the acromioclavicular joint. So these are some of the bursas which can be inflamed and which can cause the different types of pain. So I am now adding the muscles. So muscles are most important part of the muscles is the rotator cuff muscles. And just for the recapitulation, what are the rotator cuff muscles? The 4 rotator cuff muscles anteriorly. So just look at layer by layer. First, I am removing this front muscle, that is the pectoralis major. So the pectoralis major, I'm hiding. And then the 3 strips of the deltoid, anterior, I'm removing that. So whole of the deltoid went away. So anterior, middle, posterior part. And now we have exposed the rotator cuffs. So rotator cuff, let me, this was your long head and this was your short head. So I am removing the short head. Below the short head, we are having the coracobrachialis muscle. This was your coracobrachialis muscle. I'm hiding that also. So now what I am getting, let me remove that bursa also. So now what I am getting is this muscle is the subscapularis muscle. So subscapularis muscles, where it is getting originated. So I am removing the pectoralis minor muscles also. As I told you, 3 important muscles is getting originated. One is your pectoralis minor and 2 was coracobrachialis and the short head of the biceps. So I'm removing this muscle. So here, this muscle is your subscapularis muscles. So these subscapularis muscles getting originated from the anterior surface of the scapula and attached at the lesser tibia. So then let me remove this also and let us see supraspinatus muscles. So this is your supraspinatus muscles. Supraspinatus muscles gets originated from the supraspinatus fossa above of the spine of the scapula, and it comes below this acromion, below the acromion, and get attached to the superior facet of the greater tubercle. So this was the greater tubercle. So this was the greater tubercle. So this was the superior facet, middle facet, and the inferior facet. So superior facet is where the superior facet is where, superior facet is where the supraspinatus muscles gets originated. So this was your supraspinatus muscle. And you can remember the function. The most important function is your abduction. So tendinous parts get attached in the superior facet of the greater tubercle. And here we'll be discussing about the rotator cuff also. So rotator cuff is basically the interval. This is a gap. So one side we are having the supraspinatus tendon. Another side we are having this subscapularis tendon. And in between we'll be able to see the bicipital tendon. And above the bicipital tendon, we are having the coracohumeral ligament. And on the either side, either side of this bicipital tendon, there is a gap. If you are going into that, you will be going into the intra-articular space. So to go into the intra-articular space within the joint capsule, either side of this bicipital tendon through the rotator cuff, this is called rotator cuff interval. Why it is called rotator cuff interval? Because there is a gap on the either side. The bicipital, the tendon is going intracapsular there. And along the side of the bicipital tendon, you can inject something intra-articularly. So I will be discussing this also when we'll be demonstrating there. And we also will be mentioning there, as I was mentioning, that thickness of the coracohumeral ligament. So this is the coracohumeral, this was the coracohumeral ligament. Coracohumeral ligament. So this coracohumeral ligament thickness, that can be also one of the aspect of diagnosing the frozen shoulder or adhesive capsulitis. But again, it's not very sensitive. There might be some misleading reports are there. But again, still, classically, many people use that thickness, measuring the thickness of that. So if you are holding the probe this way, so one end of the probe will be having the supraspinatus muscles, another end of the probe will be having the subscapularis muscle. Along the we'll be having the coracohumeral ligament, and in the middle we'll be having the biceps, long head of the biceps tendon. So these are the different, this is anterior, the subscapularis and the supraspinatus. Now if I'm coming posteriorly, two muscles, one is this was your infraspinatus, originating from the infraspinatus fossa and getting attached with the middle facet. And below that, we are having another muscle, that is your teres minor muscle. And teres minor muscle is one thing you have to remember. I'll be showing you, demonstrating you also. Look at this teres minor. Teres minor, let me remove the infraspinatus. Now hiding the infraspinatus, you can see the joint capsule. So when we'll be seeing the humeral head, that is the area where we'll be getting the infraspinatus. But if you're coming below, when the humeral head is basically almost completing, then only we'll be able to see the teres minor. That is the reason why many people find it difficult to get the teres minor muscles nicely. So let me remove the teres minor muscle as well. And another important thing sort of will be demonstrating there. This is particularly important to understand the supraspinatus. I'm removing the supraspinatus, supraclavicular now. Let me add the knobs now. I'm adding the knobs. So you see, this is your, let me reduce a little bit. So this is your suprascapular notch. And through the suprascapular notch, this was your suprascapular notch. The suprascapular nerve was coming. This was the ligament under which it is coming. And then it take a curve and it comes here. Here, it gives the muscular branch to the supraspinatus. Then it comes down and then muscular branch to the infraspinatus and the teres minor. And articular branch, let me remove this drawing. Articular branch, which is supplying the capsule, you see, this is the articular branch which is going to supply the capsule. So if we are holding the probe here and blocking here, this is your spinoglenoid notch. This is your glenoid, this is your spinous process. So this notch is spinoglenoid notch. So if you are holding the probe here, and if we are able to see this notch on the lateral aspect of this notch, we can block it so that the muscular branch will not be damaged. Muscular branch will be saved. So this is one of the suprascapular nerve block in the suprascapular notch is nowadays obsolete. We don't block the suprascapular nerve at the suprascapular notch. We block the articular branch of the suprascapular nerve at the spinoglenoid notch. So another important thing here, what I'll be showing you there as well is your, let me add the vessels also, arteries. So here, this nerve is your axillary nerve. So this is the quadrangular space where we'll be able to see, this is at the junction of the head and the shaft. At that junction, just below the teres minor muscle, this quadrangular space where we'll be able to see this axillary nerve going laterally. So here also, axillary nerve also, posterior lateral part of the joint is supplied by the axillary nerve. And axillary nerve is also very important. Articular branch of the axillary nerve is also very important target when we are doing the denervation of the glenohumeral joint pain. So that is also important target for us. And another important target is here above the coracoid. So though it is not seen any branch here, but this is a very fine branch where the lateral pectoral nerve, this is the lateral pectoral nerve. This gives some articular branch which goes here and supply the joint capsule over the coracoid. So to block the articular branch of the lateral pectoral nerve, we press the RF probe or cryo probe over the coracoid process to block the articular branch of the lateral pectoral nerve, which normally takes care or carry the anterior shoulder pain. So if somebody is having the anterior shoulder pain, then articular branch of the lateral pectoral nerve is your target. And there we place the probe over the coracoid and we ablate there. So these are little bit of anatomy, and after sitting there, and also we can see the ultrasound probe series. Can you see it? My slides?
I can see Sanjeev Da and picture, sir. Yes, sir, I can see
it. Right. Okay. So normally we start scanning with the biceps, long head of the biceps. And the probe here, what we'll be using is your what probe? Linear probe, right. And the home position, we normally start scanning from the humerus, just below the joint. So from here, I am scanning. And what you can see here is your humerus. So the bone here was your, so this was your humerus. And above that, this muscle is your deltoid muscle. And here is the biceps tendon. It is very tendinous there. So from there, I'm going up. So from there, I'm going up. And now you'll be able to see the group. You can see the U of the humerus is now getting. So one thing I forgot to mention, that my aspect marker is towards the left side of the screen. This side is your aspect marker. So this is the medial side and this is the lateral side. So when I'm going up, gradually, I am able to see the bicipital group. And in the bicipital group, what we can see there, greater and the lesser tubercle. And also, see here, yesterday I was telling, here the bicipital tendon is looking hypoechoic. Why hypoechoic? This is a basic thing, that if the ultrasound beam is not coming back to the transducer, it will be looking hypoechoic. And now if I'm doing like this, you'll be seeing it hyperechoic. So this is now the tendon is looking hyperechoic. Let me reduce the depth a little bit. So this is the bicipital tendon, and this is your greater tubercle, this is your lesser tubercle. And if I am going up, this is the bicipital tendon. Now it is looking hyperechoic. At this position, I'll be making it long axis. So this is the long axis view. So a tendon, how it will look? Tendon will look hyperechoic fibrillar. So this is the tendon in the long axis. Tendon is looking nice. So if there is dislocation or if there is a rupture, so this bicipital group might be looking empty. You may not be able to see anything. Above this, the muscle, what we can see here is your deltoid, anterior fibers of the deltoid. So this is your humerus at the bicipital group in the long axis. So now, if let me put more gel. If I'm coming down, my aspect marker is again on the left hand side, that is medial side is your left hand side. If I'm coming down, see what is happening. So now here, this is your pectoralis major muscle. So this is the pectoralis major muscles getting attached here, and below here is your bicipital tendon, and it is getting attached over the humerus. This is the pectoralis major. So now from here I was going up, bicipital groove. Then here when I am coming here, so and at this position, this muscle is your subscapularis. Subscapularis in the long axis. But if I wish to see the subscapularis, and this is your coracoid process. This is your coracoid process. This is your subscapularis in the long axis. And if I wish to see the subscapularis, even better, subscapularis tendon. So whole thickness of the subscapularis is not nicely seen. This part is hyperechoic, this part is hypoechoic. If I'm doing a heel to maneuver, then I might be able to see it better. I see now it is subscapularis is whole of this subscapularis is looking hyperechoic. And if I'm doing the external rotation, then what will happen? The subscapularis, still more portion of the subscapularis by axis. You can see still more portions of the by. So you see, this is the whole portion of the subscapularis tendon. You can see in the long axis. Now, if I am rotating it, so now my aspect marker is up. So here at this position, I can see the subscapularis. I can see the subscapularis here. This is now your subscapularis in the short axis. So what is important here? When you are seeing in the short axis, you can see there is hyperechoic, in between the hypoechoic, again hyperechoic. Don't think that this is pathological, because here we have to understand that it is your multipinnate appearance. So because of its multipinnate appearance, it might be looking like that, but that is not pathological. So short axis of the subscapularis muscles will be looking like that. So this was the short axis of the subscapularis muscle. This bone is your non-coracoid. This is your clavicle. So when you are having the long axis, then this is your coracoid. But in this axis, short axis of this the subscapularis muscle, this is your clavicle, and below that, this is your the multipinnate appearance of the subscapularis muscle. So the biceps and the subscapularis. And now here I'll be showing you the supraspinatus and rotator cuff interval. So supraspinatus, where from it is originating, I have shown in the anatomy that if you are palpating the spine of the scapula, so above this is the spine of the scapula, which is becoming acromion. So above that, if I'm putting my probe here, it will be coming below the acromion, and it will be below the acromion, it will be coming here. And there is a ligament, coracoacromial ligament, which completes the arch, through below which it will be coming here. So now, if we put little more gel there, and let us see let me increase the depth a little more, because here. So where is my probe? My probe is above so if I'm going lateral side, this is your scapula. This is your trapezius. This is your supraspinatus muscle. So the more medial you are going, the thickness of the supraspinatus is less. Laterally you are coming, supraspinatus thickness is increasing. And look at this, we'll be getting the supraspinatus notch. Here, this is the notch, suprascapular notch. So here you can see the pulsations there.
So if you wish to block the suprascapular nerve, at the suprascapular notch, this is the target where my probe is there. So you can see the pulses in there. So that is where you have to block it. But normally, for the pain management, for the anesthesia purpose, that is okay. But for the pain, chronic pain management, if you wish to ablate the, you can see the pulses in there very nicely. So if you wish to do the permanent block, then you cannot block it there. Then the nerve to the supraspinatus, interspinatus, all this will go. So you cannot block it here. So now I am coming more laterally, and now you can't see anything because you are over the acromion now. You are over the acromion now. So now if you are coming still more, and if we are making the, so now what will happen? Now again, this was your acromion. Let me reduce the depth now. So this was your acromion, and this is your supraspinatus tendon. But supraspinatus tendon will be able to see it better if we are having the clasp position or modified clasp position. This is the modified clasp position. So this is how we can see the supraspinatus tendon is coming more, and this is your supraspinatus tendon in long axis. So this is the supraspinatus tendon in the long axis. And here, subacromial subdeltoid bursae, here there is no bursitis, but you can see a very faint black line within this white area, that is your bursae. So this is your supraspinatus tendon in the short axis, a long axis, sorry. And if you wish to see in the short axis, then you just make it like this. So this is your supraspinatus in the short axis. So here, what I was telling like before also. So if you are putting your probe one side over the coracoid, this is your coracoid, and another side, another is your over the acromion. This is your acromion. And if you are coming below, so now this is your supraspinatus. So supraspinatus basically comes like this, And if you are coming still below, so this is what is your, so let me hold the probe this side. Now medial side is your otherwise there will be some difficulty in orientation. So this was your coracoid, this was your acromion, and this is your supraspinatus. So this side is your medial side. So this side is your subscapularis, and this side is the supraspinatus. So now if I am coming down, so now I can see now the bicipital tendon. So roof is formed by, as I was telling you, roof was formed by the coracohumeral ligament. And on the either side of the coracohumeral ligament, this is the roof is formed by the coracohumeral ligament, and this ligament on the either side of the bicipital tendon, this and this is the superior spino-glenoid ligament. Superior glenohumeral ligament. As I was telling you, there are three glenohumeral ligaments: superior, middle, and the inferior. So this is your fibers of the superior, the glenohumeral ligament, and roof is by this hyperechoic area is what Sirius was telling, by measuring that we can measure. But again, if we are searching the literature, exactly how much thickness and how much thickness should be the normal, how much thickness should be for the adhesive capsulitis, lots of debates. You just search the literature and see. Some literature says 2 millimeter, some say 3 millimeter, 1.7 millimeter, lot. So that is, there is basically no definitive guideline or protocol at which thickness is normal, which is abnormal. But anyway, these black areas on the either side is your ligament, and this side is your subscapularis, this side is the supraspinatus, and the gap either side of that is your rotator cuff interval. So if you wish to go intra-articular injection, so what you can do is you can come and inject here, you can come and inject here, and this injected will be going inside the joint. So if you wish to go intra-articular joint, anteriorly you can go into the rotator cuff and you can inject there. And there also another thing you can do, if there is adhesive capsulitis, you can puncture this superior glenohumeral ligament on the other side of that. That means on here as well as here, you can puncture and you can do the fenestrations of the superior glenohumeral ligament and coracohumeral ligament as well. So this was your coracoid process, this your coracohumeral ligament. Some book also says there is some small fat pad hypoechoic area just medial, just lateral to the coracoid. This fat pad might be lost in the adhesive capsulitis. So this is the anteriorly. There are three tendons. What we should look: longer than the biceps, medial side of that is your the subscapularis, lateral side of that is your the supraspinatus. So now here two impingement are common. One is subcoracoid impingement. So below the coracoid, the tendon what is passing is your this is your coracoid. This was your subscapularis. So if I am holding the probe like this was your coracoid and this was your subscapularis. Now if I am rotating it, you can see that the greater tubercle is going inside. So this was your biceps tendon. It is coming, and this is your greater tubercle. So the lesser tubercle. So lesser tubercle is going below the acromion. This is a normal. But if there is a subcoracoid impingement, you see, this is the whole, the subscapularis muscle. If I am doing the external rotations, the subscapularis tendon is coming out. Greater tubercle is going far lateral, and if I am doing like that, so this was your biceps. So this was your biceps. This was your greater tubercle will be going below the coracoid. So this was your coracoid, it will be going below that. That is normal. So this is how to test for your subcoracoid impingement. So if there is a pathology of the subscapularis muscle, if there is a subcoracoid bursitis, then this impingement might be positive. It will not be gliding as smooth as what you can see it here in the healthy volunteer. So now another important is your subacromial impingement. So normally, if I'm doing the abduction, what happens? You see, this was the greater tubercle where the supraspinatus muscle is getting attached. So this is the greater tubercle where this is attached. And normally the greater tubercle goes below the acromion in a normal healthy individuals. I'm doing the abduction and see this is going below the acromion. The greater tubercle is going completely below the acromion. So that will not happen if there is a subacromial impingement. So this is the one impingement, subcoracoid subacromial impingement. So now let me come to the posterior aspect. So in the posterior aspect, after I'm completing these muscles and tendons, then I'll be going into the ligaments. Some of the ligaments I have already shown, but few more ligaments are there. So supraspinatus already I have shown in that if I'm going above the spine of the scapula, this was spine of the scapula. If I'm going above the spine of the scapula, this is supraspinatus muscle in the long axis, and this is supraspinatus muscle in the short axis, cardiac axis. Now, if I'm coming below the scapula, so below the spine of the scapula, this was the spine of the scapula. This is the spine of the scapula. I'm coming below the spine of the scapula, and my aspect marker, let me put my aspect marker below on the lateral side. So I'm going lateral side. So this white area is the central tendon of the interspinatus. So here, this is your deltoid, and below that is your infraspinatus muscle. This is the central tendon of the interspinatus. If I'm going medially, then this is the central tendon, and this is the muscle part. This is the muscle part, and this is the central tendon part. So if I'm going laterally, it is getting attached here, Bartbeck appearance over the greater tubercle. Greater tubercle, middle facet. Superior facet, I already told you, supraspinatus will be getting attached. Middle facet, how it will be attached, the interspinatus is getting attached. And at this point, what you can see here, this triangular hyperechoic area is your. Let me reduce the depth a little bit. And let me increase the gain also a little bit so that you can appreciate this. This is the labrum. This is your head of the humerus. This is your glenoid. And here, this is your spinal glenoid notch. This is your spinal glenoid notch. And here you can see the pulsation of the artery. You can see the pulsation here. You just look at there. I hope you can appreciate the pulsation here. So that artery is and accompanied by the nerve, that is your suprascapular artery and the nerve. So this is the suprascapular artery and the hyperechoic structure is your nerve. So here, if you are blocking it here, if you are putting the probe here, then you are not going to block the muscular branch of the suprascapular nerve. So this is nowadays done. So this is your glenoid, this is your notch, this is your head of the humerus, this black line is your hyaline cartilage, and this is your the labrum, the fibrocartilage. Fibrocartilage looks white. So now, if I am going here, teres minor, here you will not be able to see, difficult to appreciate. If I am going down when the humerus, this is your teres minor. These muscles become the teres minor. But teres minor identification, there is a easy way to identify the teres minor. So what is to be done here? So my aspect marker is again towards the humeral head, and you just look at this muscle. This is head, this is sap. Here at this junction, this muscle is the teres minor muscle. And here, this is your posterior humeral circumflex artery accompanied by the nerve. So this is your quadrangular space. So just below just distal to this is teres minor muscle, this is your quadrangular space. And here you can see the hyperechoic structure. This is your nerve and this is your pulsating artery. So this black dot is your artery. You can see the pulses in there. So this is your artery. Sometimes taking color, sometimes not taking color. You can easily appreciate the pulses there. And just on this proximal side, this is your, and this muscle is your teres minor muscle. So now, after looking at the teres minor muscles, if I am making it in the long axis, this is short axis of the teres minor muscle. So if I am going with the long axis of the teres minor muscle, so this was teres minor muscle. So now what I am doing, I am making it a long axis. Look at this muscle, keep eye on this muscle. Okay, let me rotate on this way so that aspect marker will be. So this was your teres minor, sorry, this was the teres minor. Teres minor. Now I am rotating it. Rotating it. Rotating it. So this is your teres minor muscle. And here is, remember that it comes below the, see here was your head. This is not head, this is the sap. So just below the head, where the teres minor. So this is your teres minor muscle. This muscle is your teres minor muscle. This muscle is your deltoid muscle. This is teres minor muscles. If I am going above, teres minor muscle is finished, completed, and then it is the central tendon of the supraspinatus, interspinatus. This is the interspinatus muscles with the central tendon of the interspinatus. And teres minor muscle is here. This is teres minor muscle. And I have shown you the nerve, two nerves. This nerve was in your quadrangular space. This nerve can be blocked here to block the axillary nerve. And to do the radiofrequency ablation, I'll be sending you one the video of the radiofrequency ablation of the shoulder joint, this nerve. So you have to go laterally. So here you can see the artery very nicely pulsating. If you are going more laterally, where the artery will be finished, just it will be, that is the area where the teres minor tendon is just becoming fully tendinous. So, and your cortex is just completed and you cannot see the artery anymore. So that is the time where you should be stimulating. I'm just reducing the depth so that you can appreciate it better. So now you can see at the center of my screen is your teres minor and the artery pulsating. So now if I'm going laterally, teres minor will be becoming fully tendinous and artery circumflex posterior artery will be gradually vanishing. At this point, you should target here. Your needle should be coming like that and injecting, doing your radiofrequency or local anesthetic or dextrose injection there. Okay. So now so two target, if you wish to denervate, two target I showed you. One is your spinal glenoid notch, another is the quadrangular space. Another important area is again my aspect marker is towards the medial side. And here over the coracoid, this is the coracoid, and over the coracoid, here you should be placing the needle and you should be doing it. So the coracoid, as I was telling you, the few tendons are there. Here you can see there are two tendons. One is your long head, short head of the biceps, another is your coracoacromial. So this side is your short head of the coracoid and this is your coracoacromial. And if I'm going laterally, medially, sorry. So this is the tendon of the pectoralis minor. So all these are getting attached to the coracoid. So now 2-3 ligaments are important from the coracoid process. One is your coracohumeral ligament. This is the coracohumeral ligament already have shown you. But if I am look at my probe position, I am keeping the aspect marker probe towards the proximal side of the probe over the coracoid, and I'm rotating it towards the acromion. So now the bone what is coming here is your acromion. So this ligament is your coracoacromial ligament. So one side of my probe, this is a very thick ligament. So normally it's approximately 3 millimeter in wide. So this is your coracoacromial ligament. Why the coracoacromial ligament is important? Because coracoacromial ligament is making a tunnel through which the supraspinatus muscle is coming. Look at my probe position. And if I'm coming distally, I'll be able to see this is your supraspinatus. This is for supraspinatus in the short axis. So this is supraspinatus in the short axis. If I'm going, so now this is your coracoacromial ligament. So this ligament, so this is your coracoid, this is your acromion, and this ligament is your coracoacromial ligament. So now, again, the thickness of this coracoacromial ligament can cause the impingement because you can see this is the biceps supraspinatus tendon. So this supraspinatus tendon can be impinged if that is thick. So this is your coracoacromial ligament. And now, very nicely seen, this is your coracoacromial ligament. This one. And now, if I'm going more, rotating, keeping this side of the probe over the acromion, and I'm rotating this side probe, now another bone will be coming. Another bone will be coming. That is your coracoacromial. So this ligament is your coracoclavicular ligament. So this is your coracoclavicular ligament. Lateral part of the coracoclavicular ligament is known as the trapezoid. And so this is your clavicle, this is the bone, this is clavicle, this is coracoid. So this is your coracoclavicular ligament. And trapezoid part. And if I'm going more, rotating the probe, you see how I'm rotating the probe more medially, this is the glenoid part of this ligament. And here one of the blood vessels are there. And then this area, the articular branch of the lateral pectoral nerve comes accompanying these blood vessels. So that is another target for the anterior shoulder pain, which is this lateral, the pectoral nerve articular branches. So they are going here and just superficial to that of the coracoclavicular ligament to go to supply the anterior superior part of the joint capsule. So ablation of that particular branch is important for denervating this lateral pectoral nerve for the anterior superior joint and superior part of the shoulder. So these are have I left anything? So these are the things. If you wish to have something, if you wish me to repeat something, you can ask me. Okay, intra-articular joint injection. As I told you, anteriorly you can go. And if you wish to go posterior approach, intra-articular joint. So let me increase the tape. Let me show that because that is one of the commonest, the shoulder joint injection. So you can see this was the labrum. This white line is the joint capsule. This black line is the hyaline cartilage. This is your humeral head. This white line is the glenoid, and this is your spinal glenoid notch. You can see the pulsation of the supraspinatus artery there. The supraspinatus, suprascapular nerve and artery. Okay. So now, if you wish to go inject inside, you can come here and inject here in the medial part of the labrum. So this is the area if you wish to go inject. So you have to puncture this white line. This white line is the joint capsule. So you have to come here and at this position, that means let me show you with the. So this is the area what we need. Okay. Anything you wish me to repeat?
AC joint, sir.
Oh,
AC joint.
AC joint. Sorry. Okay, so AC joint is very, very easy. So you palpate the clavicle, You palpate so my aspect, let me look at my aspect marker. So this is your AC joint. Let me reduce the depth. Okay, this side is your clavicle, this side is your acromion, and this is your AC joint. And this ligament, I forgot to show this ligament also. This ligament is your acromioclavicular ligament. Acromioclavicular ligament. And if you wish to inject here in this here, but injection here is difficult. So normally, if you wish to go for the in-plane injection with this approach is difficult. So what you need to kind of do is you just put your probe over the clavicle, palpate the clavicle and put the probe in the clavicle. So this bone is your clavicle bone in short axis. Now come distally. So this is your clavicle. This was your clavicle. I'm putting it in the center of the screen. This is your clavicle. And I'm coming distally. Now the clavicle is ending. And this is your joint. This is a joint. And now the acromion is starting. So now this bone is your acromion. So if I'm keeping it here, where the no bone is seen, so now here I can come injections, in-plane injection here or here, either from anteriorly or posteriorly, you can come and inject here. So this is for the AC joint injection, in-plane injection. So you understood in-plane injection? This is how you can, assess the joint. Another thing, the scarp test what series was telling, was the patient to go on that side and you see whether there is any subluxation. If there is any subluxation, so normally this part, joint part, and clavicular acromion part will be changing it. So if it is grossly changed, then that indicates as dislocation, subluxation. And otherwise, in osteoarthritis AC joint, that is very common. You'll be seeing the irregular surface. You can see the osteophytes there. Okay, I forgot to mention another important ligament. That is your transverse humeral ligament. I have shown you all other ligament almost. So if this is your, okay, let me finish here. So you can see this is the bicipital tendon. This was your greater and this is your lesser tubercle. And this ligament, which is connecting from this side to this side, is let me draw the pen. So this ligament is your transverse humeral ligament. And another thing to remember, if you are drawing a line here and you can depth from here to here, this depth should be less than 3 millimeters. If it is more than 3 millimeters, there will be more chance of the subluxation of the bicipital tendon. And if we are having the bicipital tenosynovitis, or if there is a lot of fluid collection inside the effusion of the glenohumeral joint, because the synovial, the sac projects out into the bicipital groove around the bicipital tendon. So if there is any effusion, normally the black side around the bicipital tendon, what you can see here, so this fluid will be increasing in amount. So this white line from here to here is your transverse humerus ligament. Okay. So anybody having any questions?
And the branch, sir, ascending circumflex humeral artery also.
Okay, so I forgot to mention another thing. So that time also I'll be showing the circumflex humeral artery. So that is as I told you, that the coracohumeral ligament thickness measurement can be misleading. Many papers says many things, but here there is more nowadays to see the thickness of the inferior the glenohumeral ligament. As I told you, there are 3 glenohumeral ligaments: superior, middle, and inferior. So the inferior glenohumeral ligament thickness measurement is basically, if it is more than 2 millimeters, then that goes more in favor of that. So how to do that? It is better to have the supine position. So let me put a lot of gel there. Look at the position of the it will be good so that they can see it after you. So
just posterior to the posterior axillary fold. So this is your humerus. I'm going more medially. This is your humerus circumference artery, just over my these things, pulsating very nicely. Now I'm going more medially, more medially, more medially. Suspect, can you come and see it when I'll be telling it? So this is the head, and here you can see the, just a minute. Just a minute, when I'll be telling you just. So this is the head, and here. So this is the head, see it? Okay, so this is your, this ligament is your, this white hyperechoic area, this is your, the inferior, the glenohumeral ligament. So this thickness normally is your less than 2 millimeter. If that is, this was your humeral head, this is a sap. So here, measuring of the thickness, that also gives some clue that whether the patient is having the adhesive capsulitis or not. And you can see the circumflex artery as well. Okay, thank you very much. If anybody have any question, you can ask me, or if you wish me to repeat some of the structures, whatever I have shown, I can repeat it again.
Sir,
Yes.
so in case of frozen shoulder, patient is diabetic female. What would be the probable, the best injection to be
The
given?
best procedure to be
maximum-
done is your hydrodilatation. You inject around 20 to 30 cc of the dextrose or normal saline injection within the joint capsule. So how to go inside the joint, I have shown you. There are two approaches. You can come from anteriorly through the rotator cuff interval on the side of the bicipital tendon, or you can come from posteriorly, just lateral to the labrum, piercing the capsule, and you can inject there. Both of them are accepted technique. And you inject a large volume, so that will be distending the joint, and it is basically equivalent to that of the manipulation under the general anesthesia. So that is the technique. And along with that, as I was telling, you can, if the coracohumeral ligament or the superior glenohumeral ligament, they are thickened, you can puncture that, penetrate that also. But the single most important technique ought to be done in the adhesive capsulitis is distend the joint capsule with some volume of around 20-30 cc of the normal saline or the dextrose injection.
Sir, if the patient is in severe pain and crying with pain, so first we have to relieve the pain. So what can we do hydrodilation during that time? Initial 3 months.
Initial 3 months, normally if the patient's pain is too much, then intra-articular steroid is that gives the best result. But if the patient is having more of the restricted movement rather than pain, pain comes only when there is a movement, then hydrodilation is the choice. But in the initial first few months phase, when the pain is too much, so that time intra-articular steroid in the glenohumeral joint is the best choice.
Okay, sir. Thank you, sir.
So do you have to supplement
Intra-articular
with
steroid injection, normally what happens, the pain reduces, but normally the movement do not reduces. But in that situation, what you have to do, you have to give the steroid, and along with that, you do the vigorous exercise program so that also be recovered. That is one way to do that. But if you are encountering the patient in the later stage, when the pain only with the movement, no rest pain, that time you can go ahead with that. Okay, Siris was telling something. Siris.
Do we need to block suprascapular articular glands
That is another option. If you normally if you are doing the manipulation, then you can think of doing the suprascapular nerve block. But nowadays, as I was telling you, temporary block during the manipulation and the GA, we can do that. But otherwise, suprascapular nerve block at the suprascapular notch is obsolete nowadays. So if you wish to block, suppose recurrent severe the adhesive capsulitis. Basically, if you are dividing the shoulder pathology, what Shiris are already told, just for the quick recapitulation, for the shoulder pain can be intrinsic, extrinsic. Intrinsic atraumatic causes can be glenohumeral, extraglenohumeral. Glenohumeral causes are adhesive capsulitis and the osteoarthritis of the glenohumeral joint. In both this situation, if the patient's pain is recurrent, not relieved, long-standing, then you can go ahead with the nerve block. Nerve block means depending on which side is pain. If it is posterior, then your suprascapular nerve. If it is anterior, then is the lateral pectoral nerve. If it is lateral, then it is axillary nerve. So you can block those nerves, either temporary or chronic cases. You can go ahead with the radio frequency or the cryoablation of these nerves. But for the ease of the manipulation or for the ease of the dilatation, to reduce the pain of the dilatation, you can go ahead with the suprascapular nerve block as a pain relieving technique that you can do under only the local anesthetic. Any other questions from anybody? No more questions? Okay, then I'm stopping. Thank you very much. And you can go ahead with the recordings. And if you have any questions, next day you can ask. Meanwhile, I'll be sharing with the Kahoot questions. You go to the Kahoot questions, which will be available for 1.5 days. So thank you very much for joining. And please go through the recordings. And if you have any questions, please don't hesitate to ask us.
Thank you, sir.
Thank you, sir.